components of this project. First, Dr. Cory Martinez, who represents the neurosciences group. The first thing that she told me when I sat in Quezon City a year or two ago, she said, Debbie, don't forget the amyloid brain pet city. You know how she is. Second, Dr. Eric Cruz of nuclear medicine and the residents that work with them. And of course, the healthcare team who work behind the scenes, who have been instrumental in making this possible. I am amazed by your persistence and dedication. I would also like to congratulate you for continuing the culture of collaboration and innovation in the pursuit of excellence. To our attendees, I hope you will learn a lot and use the knowledge that you have gained to refer your patients, to care for your patients better, hopefully improve their clinical outcomes and their quality of life. May you have a productive day ahead.
Thank you so much, Dr. Ona, for your kind words. Now, as we proceed to the core of our webinar session today, allow me to introduce our esteemed guest speaker. We are very honored to have with us this morning one of the leaders in the field of nuclear medicine worldwide. He is the Ann G. Osborne Chair and Professor of the Department of Radiology and Imaging Sciences at the University of Utah in Salt Lake City, Utah, USA. His scientific contributions in the field of neuroscience include the discovery of very early signs of Alzheimer's disease in the posterior cingulate cortex and invention and worldwide dissemination of diagnostic statistical mapping technology. He has published numerous peer-reviewed articles, book chapters, review articles, proceedings, and abstracts, and has given educational lectures extensively throughout the globe. He served as the president of the Brain Imaging Council for the Society of Nuclear Medicine and Molecular Imaging, the chair of the SNMMI Scientific Program Committee, and president of the SNMMI back in 2018 to 2019. He was also the chair of the Molecular Imaging Committee for the Radiological Science Society of North America, or RSNA. He is currently serving as the chair of the SNMMI Value Initiative and the chair of the Board of Trustees. RSNA Research and Education Foundation. He also works with the United Nations, the International Atomic Energy Agency, or IAEA, to advance neuroimaging and dementia. He has received multiple awards, including the Tettelman Memorial Award in 1996 and Co-Lassen Award in 2006 from SNMMI. He has received the gold medal from the American Roentgen Ray Society in 2013, the Clinical Teaching Award of the Year in 2014, the University of Washington Presidential Entrepreneur Faculty Fellow Award in 2014, the SNMMI Presidential Distinguished Service Award in 2016, honorary member of the Japanese Radiological Society in 2018, SNMMI Fellow in 2019, Healthcare Design Top 10 MVP Award in 2020, and other countless distinctions. Ladies and gentlemen, doctors, let us all welcome Professor and Dr. Satoshi Minoshima.
Well, thank you very much, Dr. Santos, for your kind introduction. I hope you can hear me. And I'm going to actually share a slide. Saving a woman today.
Saving a woman today.
Professor, you're muted.
Can you hear me?
Yes, Professor, we can hear you.
Okay. And can you see my screen as well?
Yes, Professor, we can see your screen.
Oh, that's great. Thank you. Thank you so much. Before starting this lecture, I would like to thank Dr. Bandon and Dr. Pascal for your very kind invitation to the webinar today. I'm very excited to be here. I'm asked to talk about amyloid PET. So I'm going to actually start with amyloid cascade hypothesis theory. When we autopsy the patient who died from Alzheimer disease, in the brain, there are two peculiar changes, and one of them is called senile plaque, and the other one is called neurofibrillary tangles. And over the last almost 100 years, there has been extensive investigation what these pathologic abnormalities are. And now we understand that Alzheimer disease, the senile plaque, has a very dense deposition of abnormal protein called amyloid. And based on this observation, Hardy and Higgins, you can see the date 1992 published in the Science. Maybe the pathogenesis of Alzheimer's disease is based on this abnormal protein deposition, a beta protein. And this really formed this amyloid cascade hypothesis. And for the last 30 years, after this theory was proposed, many investigators, they focused on this amyloid cascade hypothesis, and they conducted research from molecular research to imaging research. And in this amyloid cascade hypothesis, this abnormal protein A beta accumulation in the brain, and this A beta actually starts with the amyloid precursor protein, APP. And there are two enzymes, so base enzyme or beta secretase and the gamma secretase. Those two enzymes actually interact with each other and they cleave this APP and this abnormal A beta peptide. And that accumulates in Alzheimer patient. And when this increased A beta level within the brain, that starts accumulating within the brain tissue, and that can cause cascade of pathologic changes from a synaptic dysfunction to eventual neuronal loss and dysfunction, cognitive decline, and dementia. So this entire cascade, starting with amyloid, abnormal amyloid deposition to dementia, this is really the basis of amyloid cascade hypothesis. So based on this hypothesis and observation, extensive research, in 2004, there is a first radio tracer that stick to amyloid deposition in the human brain. It is called Pittsburgh compound B, labeled with carbon 11, was developed. And this was the first successful PET radio tracer to visualize amyloid accumulation in human brain. And this publication 2004, as you can see that a blue line is a number of publications in the PubMed concerning amyloid and amyloid PET imaging. and there has been a huge amount of investigation, as you can see at this time. The largest number of imaging publication really concerned about amyloid PET imaging. And then it's very exciting to hear that this technology is now available in Philippines and St. Luke's Medical Center. I heard the first patient has been scanned this week or last week, so it's a very exciting time. Carbon-11 PAB, the first radio tracer, still considered to be a gold standard in research application, but carbon-11 is very hard to commercialize because of the very short half-life. So this radio tracer was converted to a F18 labeled radio tracers, and there are 3 radio tracers which successfully obtained FDA approval and commercially became available. So I assume in Manila, one of those radio tracer is probably will be used for amyloid PET imaging. And those 3 tracers, they're actually very similar, but there are some differences, and these are summarized in this slide. So the dosage for injected dose, flobetapir and the frutometamol and the flobetaben, these are slightly different recommended dose. And also uptake time, just like FDG PET, you inject radio tracer and wait for minutes and then scan patient. This waiting time is also different among those 3 tracers. And also acquisition duration, so how long PET imaging need to be performed, they're also slightly different. And also acquisition time really depends on the sensitivity of the PET scanner used in the clinic. So it is kind of important to remember that carbon-11 PAP was the initial radio tracer which translated to F18 labeled tracers, but those 3 tracers have a slightly different characteristics when applying to human subject. And this waiting time also differ among 3 radio tracers, but this is determined by the tracer kinetic analysis. So if you take a look at the healthy control and the Alzheimer patient after injection, radio tracer typically reaches a pseudo equilibrium. So this uptake becomes relatively flat, and that's the best time to obtain PET imaging after injection. So like in this case is F18 amyloid, about 30 to 50 minutes after injection is an optimal time to acquire PET imaging data. And the patient preparation for amyloid imaging is relatively straightforward. Actually, even it's simpler than conducting FDG PET, which is extensively used for cancer staging. So there is no dietary or hydration requirement. And we can measure patient weight to calculate SUB, but for the SUBR analysis, which I'm going to actually talk about later, semi-quantitative analysis, we even don't need to have a patient weight measurement. And the patient can be just sitting in sitting comfortably during and after radio tracer injection. Eyes can be open or eyes can be closed. I think I recommend consistent condition, but it doesn't affect visual cortex like FDG brain PET imaging does. Patient can actually use a toilet during uptake period, and also just before imaging, because imaging takes about 10 to 20 minutes, suggest patient to go to a bathroom. Sedation can be used if the patient is nervous or patient is moving around. Most likely this effect of sedation is very small, but exact mechanisms or interaction is still not known. So those people who are actually performing an FDG PET scan, it is relatively easy to do amyloid PET imaging because there is much less restriction as to how to prepare a patient. And once you acquire images, then clinical interpretation of amyloid PET comes to nuclear medicine reading group. And I'm going to actually show some cases and some caveats when reading amyloid PET imaging. But it is very important to remember that this amyloid PET imaging was developed to detect beta amyloid deposition in the human brain, and not necessarily the diagnosis of Alzheimer's disease itself. And I'll actually go into some of those aspects using cases. And in the FDA approval in the United States, the clinical interpretation is required to state either positive or negative. And this is a little different from many nuclear medicine interpretation we do. So either positive or negative, and there is not in between. And also this positive and negative should be a report impression. It's not this scan is Alzheimer's disease or not. It's really the amyloid PET imaging is detecting amyloid deposition or presence of amyloid in the human brain. And just starting with the negative amyloid PET images, you can just take a look at it. So the negative scan is not like there is no activity. There are lots of activities in negative amyloid scan. And most of those dark area, this corresponds to white matter and white matter tracts. So these are what we call non-specific uptake. So this uptake is not binding to amyloid deposition, but maybe because of the high lipophilicity of the radiotracer. Radiotracer itself has an affinity to white matter, and that's what we are actually seeing on the negative amyloid PET scan. And it's kind of interesting to remember that this is a white background and black color scale. But if you inverse this to a black background and white color scale, then the same normal images just look like this. And those people who are working in the neuroradiology, this appearance of negative amyloid scan is just like T1 weighted MRI scans. So that's how you can remember that negative amyloid scan. If you display those images with a black background, it looks like T1 weighted MRI scans because white matter has lots of activities. And when amyloid scan is negative, what does that mean? So there is a non-specific uptake, and the gray matter is less than the white matter uptake. And but the negative amyloid PET means there is sparse to no amyloid plaques in the brain. So this is inconsistent with a neuropathological diagnosis of Alzheimer's disease and reduces the likelihood that the patient cognitive impairment is due to Alzheimer's disease. So if you have a negative case, it actually does help patient management because the patient is less likely having Alzheimer's disease. So negative PET scan, amyloid PET scan has a very important value in the clinical management and practice. And the next case, is this amyloid PET positive or negative? And if you take a look at this image, and if you remember the previous presentation, so the negative amyloid PET has lots of white matter activity and almost looks like a white matter skeleton. But this scan has somewhat more diffuse black color throughout the brain. And also, this white matter skeleton is not as distinct as negative amyloid PET scan. So this is a typical example of positive amyloid PET scan. So very diffuse uptake, and this dark area goes all the way to the margin of the brain. And also, you don't see much white matter skeleton, uptake like you saw in the negative amyloid scan. And when you see positive amyloid PET scan, what does that mean? That means there is a moderate to frequent amyloid plaques and amyloid deposition in the patient's brain. But it's very important to remember that positive amyloid scan does not establish a diagnosis of Alzheimer's disease or other cognitive disorders. And I'll show you some example later. But this amount of amyloid plaque is often present in the Alzheimer patient, but patient with other neurologic condition or even in the elderly patient with normal cognition may have certain degree of amyloid deposition. So when amyloid negative scan, we can conclude patient is less likely having Alzheimer's disease. But when the amyloid is positive, then we have to be a little careful how we're going to actually write the impression of the amyloid PET scan, because we shouldn't say this is Alzheimer's disease. And because there are some other conditions which actually shows increased amyloid deposition, such as dementia with Lewy bodies, and even elderly patient with normal cognition may have amyloid deposition as well. But just magnifying this normal scan and the positive scan, as you can see that this gray matter in the normal scan is less than the non-specific white matter uptake. But positive scan, this dark area goes all the way to the margin of the gray matter. And this white matter skeleton is much less conspicuous on the positive scan. So these are basically positive and negative amyloid PET imaging features. And just comparing again negative scan and positive scan. In the clinic, one thing you can actually try or you can do is to use this cerebellar peduncle as a kind of an anchor point. So as I said, white matter has a lot of non-specific activity. And when you display amyloid PET images on the computer screen for interpretation, you can take a look at the cerebellar peduncle and try to adjust this color intensity to the certain level for all the patients. Then you'll be able to calibrate visually. All the scans are kind of normalized to this high intensity uptake in the cerebellar peduncle. And the negative scan, the only area equal or exceeding this peduncle is really a white matter. But in the positive scan, this gray matter activity all the way to the margin of the brain is either equal or exceeding this cerebellar peduncle. So this is one of those things that next time you see amyloid PET scan on the computer screen, you can try using the cerebellar peduncle intensity as a way to normalize your display of amyloid PET imaging, either black and white or even actually on the color scale. We talked about there are 3 F18 radio tracers available, but those 3 radio tracers has a slightly different characteristics, and which is also similar for the scan interpretation. So when 3 radio tracers, they received FDA approval in the United States for clinical use, their definition of positive amyloid PET are actually slightly different. And for example, for beta-PEER, which was the first radio tracer approved by FDA, the positive scan criteria is really loss of gray matter, white matter contrast, just like this positive scan, and increased gray matter uptake. So if you take a look at the cortical uptake, that is really high. And this area of increased uptake has to be larger than the single gyrus. So that's kind of a minimal requirement to call beta-PEER positive. But compared to this, beta-Ben is increased gray matter uptake extending to the cortical margin, which is very similar, but intensity has to be moderate to pronounced. But also they're asking to confirm that increased activity basically involves 4 cortical regions, so more than one gyrus. And the fruitometamol has a somewhat similar criteria, but also they're including 1 subcortical regions also should have an increased amyloid tracer deposition. So just to remember that those 3 radio tracers, basic interpretation method is really to look at the gray matter, white matter, contrast is lost, activity goes all the way to the margin of the brain. And it depends on the radio tracer. There are some differences in how to call positive scan based on the number of areas involved with a positive amyloid tracer uptake. So for each tracer, there has been a recommendation that, and the manufacturer actually created the training module. And it is actually very important to, for each individual tracer you're going to use, you take a look at this training module provided by the manufacturer and kind of get used to abnormal scan and how to interpret those amyloid PET images. And the other guidance is that when interpreting those images, image interpretation should be performed independently of patient clinical information. So this is sometimes hard to do in the nuclear medicine because there is always an indication, but try not to be biased by clinical information. Like if the clinician is suspecting Alzheimer's disease, but when interpreting those images, you shouldn't probably know about what the primary clinical suspicion and just trying to apply neutral visual assessment and interpretation. And also, if you're working using a workstation, there may be a way to semi-quantify amyloid uptake. And I'm going to just show you this SUBR approach. Those people who are working in cancer staging using a FDG PET, all the PET images, pixel values are converted to standard uptake value, which is injection dose, pixel count divided by injection dose divided by body weight. And for the amyloid PET analysis, basically SUBR is a SUB of target regions, which is a cortical gray matter, divided by SUB reference region. And if you transform this equation, basically SUBR is a target divided by background pixel count. So in the field of nuclear medicine, we have been using this target to background ratio. So SUBR is exactly target to background ratio, but it's more modern way of saying target to background ratio on the amyloid PET images. And for the analysis of amyloid PET, this background, or often called reference region, many people use cerebellum or pons as a background or reference regions. And this is for the beta-ben SUB cutoff values. Cerebellar gray matter as a reference region, or cerebellar whole activity, or pons, or subcortical white matter activity. The cutoff SUBR value changes from 1.43 only using a cerebellar gray matter to a subcortical white matter is 0.71. So if the background has more activity, then this value is actually going to go down, and which kind of makes sense. But the recommendation is typically using a cerebellum whole activity, or actually pons as a reference region. So cutoff value is somewhere like 0.96 to 0.78. And this method has been validated for beta-ben activity. And it's very interesting when compare semi-quantitative analysis using SUBR to a visual analysis by expert. It's almost the same, but the expert analysis is actually slightly better than the SUBR number-based, cutoff-based analysis. And just one example that this was SUBR based on the whole cerebellar activity. That was a false negative. But using a pons as a reference region became a true positive, and the visual assessment was true positive. Because if you take a look at the amyloid scan, you don't see this white matter skeleton very clearly. And also activity goes all the way to the cortex, gray matter. But maybe this patient has a quite extensive atrophy, which actually sometimes look like these widened sulci, looks like a gray matter, but this gray matter activity is abnormal. And if there is actually a really kind of a severely atrophied brain, sometimes, this kind of scans can cause false negative impression. And using a SUBR, again, cerebellar, whole cerebellar reference was negative, but the PONS was positive and visual assessment was positive. So I think that one of the take-home message for SUBR analysis is that once you become familiar with amyloid PET imaging, this expert visual assessment still outperform, better than SUBR imaging. But combining those two is going to probably increase confidence of amyloid PET interpretation. And just as I showed in the previous slide, there is example of negative scan and the positive scan. And if you see a patient in the clinic just look like this, would you like to call this negative or positive amyloid scan? This is a little confusing because it looks like there are lots of white matter activity here and not much activity in the gray matter. But if you actually superimpose this to CT scan, this patient has a quite substantial atrophy, just like previous case I showed. So basically abnormal uptake goes all the way to the gray matter, but the widened sulci and the sulcus, this actually create a bit of impression that maybe gray matter doesn't have activity, but in fact, gray matter does have activity, but widened sulci due to relatively prominent atrophy can potentially create a visual impression of negative scan. So severe atrophy patient, we have to be a little careful when interpreting amyloid PET images. Also, amyloid PET scans, just as I emphasized, there is a lot of non-specific activity to the white matter, but also below the skull base, there is a quite intense activity in the salivary gland. And also in certain patients, there is a scalp uptake as well as bone marrow uptake. So these are non-specific physiologic uptake you can actually remember. And also in the last several years, there has been increasing report indicating some other neurological conditions can show positive amyloid tracer deposition. And this is just a transaxial scan, amyloid carbon 11 PIV. And if you see carefully, it is kind of interesting that somewhere in this midline, there is this increased activity almost close to the precuneus and the posterior cingulate. So without having anatomic information, we may wonder that maybe this is beginning of amyloid uptake. But if you take a look at the sagittal images, this focal uptake here actually corresponds to a small benign looking tumor. And this uptake, amyloid tracer uptake, was actually corresponding to meningioma. And the various investigators, including Johnson from Mayo, actually looked at meningioma uptake of amyloid PET tracer. And you can see that meningioma, many of those meningioma actually have elevated amyloid tracer uptake compared to other types of benign tumor, metastatic tumor. They don't have much amyloid uptake. So this is one rare condition but it's worth remembering. Meningioma does show increased amyloid radiotracer uptake. Another important knowledge we should have is the spatial distribution of abnormal amyloid uptake and also decreased FDG uptake on the FDG PET scan in dementia patients. And these are Alzheimer patients and multiple patient statistical maps obtained throughout the course of patient. And if you actually take a look at the FDG changes, initially starts in the posterior cingulate cortex and then propagate to the parietal temporal lobe and the frontal lobe. But even in the late stage, the primary sensory motor cortex here is relatively preserved. But the amyloid scan is kind of interesting. From the beginning, there is somewhat diffuse uptake, but the most extensive uptake is really a medial frontal lobe and the anterior frontal lobe. Then propagate across the neocortex, but at the end, it doesn't spare primary sensory motor cortex or occipital primary visual cortex, much more diffuse uptake throughout the brain. So when reading FDG scan for amyloid imaging, it's much more posterior dominant changes like precuneus, parietal temporal lobe. But the amyloid scan, when interpreting those scans, the changes are much more diffuse, and often the most intense uptake in the initial stage start with medial frontal anterior frontal lobe. So there are spatial discordance between FDG PET and the amyloid PET findings. So these are kind of a basic knowledge that you can have when interpreting amyloid PET scan. But there are also some caveats in the amyloid PET scan. As I said, when you see positive amyloid scan, it doesn't mean that it doesn't establish Alzheimer disease, because dementia with Lewy bodies, as you can see, has almost the same amount of amyloid deposition. And the distinction between dementia with Lewy body and Alzheimer's disease is, from a patient management viewpoint, it is very important. Choline esterase inhibitor is going to work for both AD and the DLB, but when using a neuroleptics, dementia with Lewy body patient can have a quite severe adverse reaction. So clinicians would like to know if the patient is having an Alzheimer's disease or dementia with Lewy bodies, but the amyloid scan positivity doesn't distinguish between those two. But if dopamine transporter imaging is available, then even beta amyloid PET scan cannot distinguish AD versus DLB. Dopamine scan has a severe reduction in dementia with Lewy bodies as compared to Alzheimer's disease is relatively preserved. So combining another nuclear medicine brain imaging will be able to distinguish Alzheimer's disease versus dementia with Lewy bodies. Also, I indicated in the initial interpretation kind of a guideline, elderly patient, once patient age reaches 75, 80, 90, then normal subjects, so those patient subjects are not demented and cognitively not declined, but if you do amyloid PET imaging, there is a substantial amount of amyloid deposition already happening. So when applying amyloid PET imaging to elderly patient, age about 75, 80, 85, if you see positive amyloid deposition, it is sometimes very hard to say that deposition is really the cause of patient cognitive decline, or the uptake itself is simply associated with advanced aging. There are some other conditions that amyloid PET scan can be negative, despite there are some Alzheimer changes happening in the brain as well as clinical manifestation. So certain types of Alzheimer patient has a diffuse amyloid plaque instead of a neolytic amyloid plaque. And those diffuse amyloid plaque has a less amyloid tracer affinity, so that in this patient, clinically Alzheimer's disease and even biomarker CSF shows there is elevated amyloid. But if you do amyloid PET imaging, the uptake is only mildly increased as compared to a white matter. And the autopsy results shows this patient had the diffuse amyloid plaque, but less amount of neuritic amyloid plaque. And the amyloid PET can be negative in this kind of situation. And the more rare situation, certain familial Alzheimer patient or gene mutation, some mutation, amyloid deposition doesn't really have affinity to amyloid PET imaging. So this is a young control and the aged control. Typical Alzheimer patient has an increased amyloid PET tracer uptake, but this particular mutation, familial Alzheimer disease patient, the uptake is almost equivalent to the aged control, much less than the typical Alzheimer patient. So certain types of Alzheimer patient with diffuse plaque, those patient amyloid PET may not be positive or only mildly positive. We have to be very careful. And also aged normal subject, advanced age itself can show positive amyloid, even patient is not demented. And also amyloid PET cannot distinguish Alzheimer's disease versus dementia with Lewy bodies. So using amyloid PET imaging most effectively, appropriate use criteria becomes very important. And myself and the colleagues actually worked to establish when to do amyloid PET imaging is appropriate and when is not inappropriate. And so there are three scenarios that amyloid PET imaging can be medically useful, which is if the patient has a positive Alzheimer's disease clinical diagnosis, but somewhat clinical presentation is atypical, or maybe the Alzheimer's disease patient had the previous stroke or vascular instance that then on top of it, when patient develop dementia, is the patient developing Alzheimer's disease or no? That's a big question. So possible Alzheimer's disease is one appropriate use of amyloid PET imaging. Also, I explained mild cognitive impairment. So this is milder patient beginning earlier stage of possible Alzheimer patient. And if this MCI can be caused by many reasons, not just Alzheimer's disease, but if the MCI is persistent and progressive in the early stage, maybe amyloid PET imaging may be useful. And also atypically early age of onset, age before 65 years old. And these patients who develop Alzheimer's disease age below 65 years old is relatively rare. But those patients actually come to a nuclear medicine clinic because they are still functioning, having a memory decline, dementia. It's a huge issue for the patient. And those atypically early age of onset, age below 65, amyloid PET imaging may be really well suited to evaluate patient. But also inappropriate use, there are many inappropriate situations like clinical diagnosis, including MRI and FDG PET, typical Alzheimer's disease. So probable Alzheimer's disease, then we don't need to do amyloid PET imaging, which is very expensive. So clinical diagnosis accuracy can be already more than 85%. And the cognitive complaint cannot be confirmed by clinical exams. The amyloid imaging may not be useful unless if there is a confirmed cognitive impairment. And just to determine dementia severity, because amyloid uptake goes up from the beginning and doesn't really well correlate with the dementia severity. In fact, FDG and tau imaging, they actually have a much better correlation with the dementia severity. So amyloid is not indicated for severity evaluation. And when patient had a positive family history, or instead of doing genotyping, try to use amyloid PET imaging is probably inappropriate. And also asymptomatic individuals, so there is no cognitive impairment, and doing amyloid imaging is not very helpful, especially in advanced age patient. And also non-medical use, such as legal use, insurance coverage, or employment screening, we shouldn't use amyloid PET imaging. And because this appropriate use of amyloid is very important, I'll give you three interesting representative cases. So case one is an 83-year-old female, 5-year history of gradual cognitive decline, and cannot perform daily tasks anymore. So patient is becoming demented. No family history of Alzheimer's disease. The patient referred to a memory disorder clinic. Mini mental state exam score is 23. So the cutoff is about 25. So clearly MMSE score is abnormally decreased. Laboratory test, thyroid hormone B12 is normal. Neurological exam is unremarkable. MRI 1 year ago with mild vascular changes and atrophy. And the clinical diagnosis suspicious for Alzheimer's disease. And at the medical center, there is no anti-amyloid treatment available for clinical trial. Do you think for this patient, amyloid PET imaging is appropriate or not appropriate? So the answer is no, because this patient already based on the standard clinical evaluation, most likely having a probable Alzheimer's disease, and further using amyloid PET imaging, which is not the perfect test, is not really needed, and this patient can be treated as a probable Alzheimer's patient. So the case 2 is a younger patient, so 69-year-old female, history of Parkinson's disease, and the recent development of memory decline, and they refer to a memory disorder clinic. Suspected dementia with Lewy bodies versus early Alzheimer disease, and consideration for choline esterase inhibitor treatment. And the clinicians would like to differentiate dementia with Lewy bodies versus Alzheimer disease prior to the treatment. Do you think amyloid PET imaging is indicated in this clinical situation? And this is probably easy because, as I said, amyloid PET imaging cannot differentiate dementia with Lewy bodies and Alzheimer's disease, so the answer is no. And the most likely, whenever you see this kind of patient, you can actually suggest dopamine transport SPECT imaging or FDG PET imaging and take a look at the occipital cortex or cingulate island sign. Okay, so this is a case 3. 58-year-old male, 2-year history of gradual cognitive decline, and a family member concerned about his personality change and the visited neurology clinic. Mini mental state exam score is 25, so it's a borderline. Laboratory tests are unremarkable, and the MRI, no focal lesion, mild frontal atrophy. And did the FDG PET scan differential diagnosis of AD versus FTD, but wasn't conclusive diffuse metabolic hypometabolism, but somewhat atypical for AD or FTD. So in this situation, amyloid PET is indicated or appropriate for clinical evaluation. So the answer is yes. This is a younger, early onset patient, age below 65, and a somewhat atypical course as Alzheimer's disease, and even FDG couldn't differentiate AD versus FTD. So if you do amyloid imaging and the amyloid positive, then more likely the patient is suffering from Alzheimer's disease instead of frontotemporal lobe dementia, which is amyloid negative dementia cases. And this kind of a use of appropriate criteria and the clinical outcome or benefit of using amyloid PET imaging, this has been extensively debated. When amyloid PET imaging was developed, there was no consensus if the amyloid PET imaging is really helped dementia patient. So in the United States, there was a new clinical trial called the IDEA study, Imaging Dementia Evidence for Amyloid Scanning. And in this nationwide trial, basically there are 2 specific aims. So one of them is looking at if using amyloid PET imaging, is this going to change patient management? And the aim 2 is that by adding amyloid PET imaging, which is expensive, but by adding expensive amyloid PET imaging, maybe the hospital resource usage is going to go down, such as hospital admission or emergency room visit. And this study is actually still ongoing with a new IDEA study extending inclusion criteria for minority population, and also carefully looking at the healthcare outcome. And from an original IDEA study, when by adding PET imaging, as you can see, both for demented patient as well as mild cognitive impairment patient, when PET scan is positive, then the use of Alzheimer drug, symptomatic drug usage significantly increases, and these are actually clinicians' decision. And when PET scan is negative, then the use of Alzheimer drug actually decreases both in dementia patient and the mild cognitive patient. So PET scan clearly can affect clinicians' management decision-making for Alzheimer patient. I'd like to mention anti-amyloid therapy and amyloid PET. I think this is one of the most exciting development last year and this year in the United States, and also debated internationally. So what we would like to do as a nuclear medicine physician is really, and or radiologist, is really establish early diagnosis of dementia and guide patient to the right treatment and management, hoping that patient outcome is going to improve. And the first time in the history that aducanumab, which is a monoclonal antibody targeting amyloid deposition in the human brain, and by infusing this drug is going to clear amyloid deposition in the human brain. So in the drug development as well as research, amyloid scan has been extensively used. As you can see with the dose escalation, this is a baseline and the patient received aducanumab treatment. You can see clearly improvement of amyloid deposition in patients suffering from Alzheimer's disease. And I think this is really remarkable. So drug is working as intended to clear amyloid deposition in human brain. But the trouble was that, so there are two large clinical trials conducted for the aducanumab, and almost the same number of subjects involved, 1,600 patients. And one study didn't show any outcome benefit. And the other study actually showed close to statistically significant outcome benefit. So same drug, two clinical trial, similar number, slightly different patient characteristics, but one trial didn't show any effect. The other trial showed mild effect. And also this trial, patient treatment associated with quite actually significant side effect, which is called amyloid-related imaging abnormalities. So those patients who received antibody treatment, they developed brain edema and also microhemorrhage during a treatment. And interestingly, those area of edema and microhemorrhage, you can see the susceptibility weighted MRI images. So those area actually corresponds to pretty dense amyloid deposition in the patient. So drug is working to clear amyloid, but also developed edema as well as microhemorrhage as a side effect. And this change is reversible in this patient. Multiple MRI shows edema and the area development eventually cleared. And the cognition started as a mini mental state exam score of 90, 29, and eventually the MoCA score ended 30. So came down and went back. So amyloid treatment, this is really wonderful research effort and development effort, but it's not just a benign treatment. I think can have a substantial side effect demonstrated by MRI and the clinical symptoms. So when US FDA decided to approve this drug for Alzheimer's disease, there was a huge controversy internationally. Is this a right decision or not? Even amyloid imaging showed a decreased amyloid deposition, but Alzheimer's drug approved despite doubts about effectiveness. So this controversy really continues. Again, going back to the initial slide, as a nuclear medicine physician and radiologist, we like to help establish early diagnosis. We saw treatment became available last year, but still, I think the patient outcome from this treatment is unknown. And one of the reasons, actually, there are several reasons why this treatment is working or not working. And many investigators really discussed last year about is this amyloid cascade theory. Again, entire Alzheimer's disease, starting with amyloid deposition, still is a theory that need to be validated. Is this a right theory? And also relates to the clinical outcome. Or maybe there is an issue of co-pathology in the elderly patient, which I'm going to show you a few slides. And also this treatment is very expensive, so coverage cost and the accessibility to the treatment became a major issue. And I think all of those, still we have to work pretty hard to establish effective treatment for Alzheimer's disease. And the part of this co-pathology and new disease, this is a very important knowledge we should have when interpreting scans. So like 10 years ago, 20 years ago, when molecular imaging and the MRI scan became available for quite extensively applied for dementia patients, we tried to differentiate Alzheimer's disease from temporal lobe dementia, dementia with Lewy bodies, so dichotomous or trichotomous kind of a differentiation. But based on many years of quite extensive pathological investigation, those neurodegenerative conditions actually overlap quite significantly, which is called co-pathology. especially in the elderly patient, pure Alzheimer's disease versus Alzheimer's disease plus other neurodegenerative disease, these becomes very common. So these are just the literature examples that Alzheimer's disease and the TDP-43 encephalopathy actually overlaps. Even Alzheimer's disease, cortical basal degeneration, which is considered to be a frontotemporal lobe dementia, overlaps. PSP and the Alzheimer's disease actually overlaps quite significantly. So PSP is a tauopathy, 4-repeat tau, and typically considered to be a spectrum of frontotemporal lobe dementia, but the Alzheimer's disease, they actually coexist. And we just published this review paper in the Journal of Nuclear Medicine. This is a FDG scan, and post-mortem actually shows PSP, progressive nuclear palsy, and Alzheimer's changes altogether. So PSP changes such as midbrain hypometabolism and the frontal hypometabolism is more feature of PSP, but retrospectively, you can appreciate posterior cingulate precuneus parietal-temporal changes. These are mild Alzheimer's changes. So basically, AD and PSP coexist. Also, there has been a new disease dementia category discovered more recently, and these are actually listed here. So TDP-43, limbic predominant age-related encephalopathy, often abbreviated as a LATE, and hippocampal sclerosis, PART, primary age-related tauopathy. Thanks to a prevalence of tau PET imaging, investigators are finding that patient demented only having a tau, but the amyloid negative dementia patient. And also agile-philic brain disease, AGD, is this similar hippocampal involvement, but the pathologic depositions are different, and part of that frontotemporal lobar degeneration. So these are actually now better characterized in clinical pathological correlation. Interestingly, all of those newly recognized diseases, they actually affect hippocampus. And it is interesting, like 10, 20 years ago, hippocampal atrophy is one of the hallmarks for Alzheimer's disease. But nowadays, if you see severe hippocampal atrophy, instead of worrying about Alzheimer's disease, we may actually have to differentiate some of those diseases, such as late limbic predominant age-related TDP-43 encephalopathy. And there was a consensus criteria just published 3 years ago. So this is really new category of dementia, but affect mostly advanced age above 80. And autopsy data actually show 20 to 50% of patients who died and got the autopsy age above 80 at the late pathologic changes. And so people are speculating maybe the public impact is almost similar to Alzheimer's disease. But the clinical symptom is very hard to distinguish from Alzheimer's disease, and except maybe the progression is slower than the slow progression as compared to a pure Alzheimer's disease. And there is no PET imaging tracer to visualize TDP-43 encephalopathy, but you can actually do an FDG PET scan. This is widely available. And if you take a look at the Alzheimer's disease and the dementia with Lewy body, this is a Z-score map. Medial temporal lobe is relatively spared in the Alzheimer's disease versus dementia with Lewy bodies. But in the late limbic predominant age-related TDP encephalopathy, there is a severe hypometabolism involving medial temporal lobe and also frontal and the orbital frontal cortex. So clearly this is a FTD pattern, but when you see the severe metabolic reduction in the medial temporal lobe, and in the elderly patient, maybe the patient is suffering from a late instead of AD or DLB or FTD. And if you do a quantitative volumetric analysis in the clinic, this is the same patient, you see a severe atrophy in the hippocampus, and the neuroquant analysis clearly shows disproportional atrophy in the hippocampus and medial temporal lobe. But I think one of the most important message here is that this amyloid and the tau and TDP-43 newly recognized biomarker, and the alpha-synuclein, which is Parkinson's disease and dementia with Lewy bodies. there is a substantial overlap between those proteinopathy and the coexisting co-pathology, especially in the elderly patient. So when nuclear medicine and radiology, we still try to differentiate, let's say, Alzheimer's disease versus DLB, Alzheimer's disease versus FTD. But from a therapeutic viewpoint, targeting specific protein aggregates, we need to remember there is a substantial overlap between AD, FTD, DLB, and the late, and even new abnormal markers such as FUS and the FET. So co-pathology and mixed dementia, if you do amyloid PET imaging, if there is an amyloid positive, that means there is an amyloid, but it doesn't mean Alzheimer's disease. Patient may have a PSP, or patient may have a coexisting TDP-43. And then finally, just a few slides, dementia care cost and fluid biomarkers. So dementia is a widely prevalent disease in the elderly people. And this is Alzheimer Association estimate in the United States that a huge amount of healthcare costs will be consumed by Alzheimer disease or dementia care. In fact, there was a paper published in the JAMA last year when this new drug, aducanumab, was approved. And it's not just the cost of the drug, which is very, very expensive, but also by doing an MRI, it's going to add $1 billion to the CMS Medicare spending. And by adding an amyloid PET imaging, it's going to be a $2.6 additional billion to your Medicare spending. So even though we know MRI, PET, and these are very important, and for the treatment, drug is very expensive, but just the national healthcare system cannot pay for everything from a treatment to a PET imaging to MRI imaging. So there has been extensive development of fluid biomarker, which can be easily obtained, but also can potentially be cheaper. So starting with CSF and the blood-based fluid biomarker research, there was a seminal paper published in the Nature 2018 by Japanese investigator collaborating with the Australian group using high sensitivity mass spectroscopy to detect it's a composite index of amyloid, circulating amyloid protein, and differentiation between normal subject versus Alzheimer's disease or amyloid positive patient defined by PET imaging, almost equivalent. And similarly, but using a simpler method such as looking at the ratio between A beta 42/40 from a plasma, so it's a blood test, and almost this accuracy of differentiating amyloidosis patient, positive patient compared to PET imaging. So these are really promising development. But still, PET imaging, amyloid PET imaging is better standardized. And also we can take a look at the regional changes, like very small changes beginning in the Alzheimer patient. So maybe the integration of fluid biomarker is going to be really clinical evaluation first, then standard MRI, FDG, PET, and maybe to add fluid biomarker. And if these are discordant or not diagnostic, then goes to more dedicated PET imaging, such as amyloid and tau PET imaging. So this is a summary for today's discussion. Amyloid cascade hypothesis is the basis for this extensive research development for amyloid PET imaging. And we just reviewed how to perform amyloid PET imaging, which is relatively easier than FDG brain PET imaging or FDG cancer imaging. And the clinical interpretation of amyloid PET through some cases, there are some caveats we have to remember. Like meningioma can be amyloid positive. Some Alzheimer's disease doesn't have an amyloid positivity. And elderly advanced age itself without dementia can have an amyloid positive. And the amyloid PET can be positive between Alzheimer's disease and dementia with Lewy bodies. Both of them are positive. So appropriate use criteria is very important. This is evolving. In fact, we're actually working on the second version of appropriate use criteria between SNMMI and the Alzheimer Association right now. And amyloid PET imaging is a major tool to develop anti-amyloid treatment. But the anti-amyloid treatment, I think the first drug approved by FDA, still, I think it's a mildly effective or confusing outcome. So still research and development has to continue. Part of this, we need to remember there is a new disease such as late limbic predominant age-related TDP-43 encephalopathy, and also Alzheimer's disease can coexist with a traditional way of frontotemporal of dementia with Lewy bodies. And all in all, the cost of dementia care is going to be a major burden on any countries and the societies, and maybe the development of less expensive approach, a widely available approach such as fluid biomarkers may be a very important tool for dementia evaluation for the future. So thank you very much for your attention. Thank you.
Thank you so much. Thank you, Dr. Minashima, for that extensive and enlightening lecture, not only on the fundamentals of amyloid brain PET imaging, but also its future role in the management of Alzheimer's disease. Truly, there is so much to learn from the experts. Now, I can see that we already have a lot of attendees in our session today, over 140 people. So moving on to the next segment of our session, to moderate the Q&A portion of this webinar, and to facilitate further discussion, I call on the training officer and the research committee head of the Department of Nuclear Medicine and Theranostics in St. Luke's Medical Center, Quezon City, Dr. Irene S. Bandong.
Hello, everyone. Thank you very much, Professor Minashima, for that very concise and very informative lecture. The floor is now open for questions. First question is from Dr. Socorro Martinez. Is there already a value for the SUVR that may indicate that we are dealing more with AD in individuals with difficult to diagnose cognitive impairment?
I didn't talk, much about statistical mapping of amyloid PET imaging. So basically, this SUVR, which is a ratio method, once we use reference region, convert pixel value to the SUVR value, then we can apply statistical mapping just like we do for FDG PET, then take a look at the distribution of abnormal amyloid uptake. And based on the extensive experience using amyloid PET imaging and the statistical mapping, this Alzheimer's disease, as I briefly mentioned, in the typical cases, sometimes starts in the medial frontal lobe, and then a kind of a diffuse uptake throughout the gray matter. But also, there are certain cases which focal amyloid uptake starts at the other part of the brain. And these are relatively mild patients, typically mild patients. So by doing a SUVR-based statistical mapping, we'll be able to detect some of those localized, FDG uptake, amyloid tracer uptake in the relatively early stage of dementia. And my speculation is that if you do a blood-based test, those small changes may not show up on the blood test, or blood test variance, can be quite large. And maybe the blood test can be still negative, but maybe the amyloid PET can detect smaller changes, which eventually propagate, throughout the brain. That's my actually hope.
Thank you, Dr. Minashima. Another question from Dr. Jacqueline Dominguez. Thank you, Professor, for a nice lecture. Is there any updating going on the appropriate use of criteria in the light of the availability anti-amyloid therapy?
Yes. So this is very, very important question. And just as I mentioned in the last slides, SNMMI and the Alzheimer Association, we started working together last year, and we are updating amyloid PET appropriate use criteria, which is already 10 years old. but also including a tau PET into appropriate use criteria. And I just gave a brief lecture at the SNMMI annual meeting in Vancouver, and still actually in work in progress, but slightly expanding application, including in the setting of anti-amyloid treatment availability. Clearly, amyloid PET imaging is going to be appropriate because you need to confirm, patient does have amyloid, deposition before treating with anti-amyloid therapy, which also have a side effect. So you have to estimate risk-benefit ratio. And the confirmation of amyloid by amyloid PET imaging before the anti-amyloid treatment is so important. And in the United States, there was a FDA public comments period about 2 months ago. Can we do 2 amyloid scans in patients, treated with anti-amyloid treatment? So one before the treatment to confirm, and the second amyloid PET scan after treatment, if the drug is really working or not. And this decision hasn't been announced, but there was a public hearing comment in the United States.
Thank you, Professor. For another question from Dr. Socorro Martinez. Is amyloid PET scan be utilized for investigation in multiple sclerosis?
That's an interesting question. And because in the negative scan, there are lots of white matter changes. And if I remember correctly, I did this search several years ago. There are some people looking at the white matter uptake and the MS changes, but I'm not up to date in what the latest agreement or understanding of amyloid PET imaging in multiple sclerosis. In the molecular imaging viewpoint, one of the exciting aspects is that we have neuroinflammation tracers, and even actually including a TSPO ligand, which is a traditional neuroinflammation ligand. There has been application to multiple sclerosis. So instead of looking at the MRI findings of white matter changes, TSPO ligand PET imaging is going to be able to elucidate what MS plaques are active or not active in terms of inflammation. So I think it's a very exciting field of research, and hopefully PET imaging is going to use more.
Thank you, Professor. Another question from Dr. Jamie Licano. Thank you for the lecture. Would you recommend amyloid PET results be generated as SUVR per ROI and visual amyloid distribution? And will our amyloid PET results be generated in a similar way?
Would you recommend amyloid PET result be generated SUV per ROI plus visual distribution? So I think this is another very important question. So the paper published, and I showed on the slide, this is specific to a flurobetabin, and I understand maybe flurobetabin is going to be available at the St. Luke Medical Center. I may be wrong, but their recommendation is to combine both. And for flurobetabin result, SUVR was really good, but it's not as good as expert visual interpretation, such as if the reference region, such as whole cerebellum, as you know, once the Alzheimer's disease progresses, cerebellum can actually show amyloid deposition. And if the reference region has an amyloid deposition, then sensitivity actually goes down if we use SUVR. But visually, you'll be able to detect, gray matter, neocortical gray matter uptake, as well as you can actually assess cerebellar uptake. So my recommendation is combine both. But I think this also becomes a major discussion, not just for PET, but the MRI borimetric analysis, because the visual impression is ambiguous and the value, semi-quantitative value says abnormal. Should we say abnormal or not? I don't think there is a consensus which way we should go. My own personal opinion is that we should confirm by visual assessment, regardless of the number, but the number is going to support visual assessment. And that's what we should reflect in impression. just like those people working in a nuclear medicine, we do a cardiac bullseye, right? And even we have a bullseye, you take a look at the reconstructed images, short axis, long axis, you try to see the actual findings, then confirmed by bullseye, not just to read bullseye. So maybe same approach can be applied to amyloid PET imaging.
Thank you, Professor. We in St. Luke's Medical Center, we provide both the visual analysis interpretation as well as the regional SUVR, and we are using the floor beta then.
Okay.
Another question from Dr. Maria Cristina Macrohan Valdez. Can amyloid PET scan help distinguish CTE from AD where patient's CSF tau protein is not significantly high?
This is an interesting question. I think it's an ongoing question. There has been quite a few applications of amyloid PET imaging in the CTE patient chronic traumatic encephalopathy. And some paper actually suggested in the CTE or chronic phase or conversion from acute phase, so the amyloid deposition goes up and comes down. So it's a very transient increase in the amyloid deposition after head trauma. And then transition to a CTE. And the current tau PET imaging, one trace approved in the United States, specifically excluded application to a CTE because we don't have enough evidence to show tau PET imaging is really useful for CTE patient or not. But I think this is something that we have to continue to investigate. And one of the challenges that if you actually take a look at the literature, some of the CTE papers, the patient population included is actually can almost reach 60 and 70 years old. So amyloid positive and the tau positive in the setting of cognitive decline, is this really based on the CTE or based on developing let's say Alzheimer disease and other things? There are some difficulty differentiating between those two in the literature, but I think amyloid PET imaging and also neuroinflammation and tau imaging in the CTE, very, very important field of research.
Thank you, Professor. Here's another question. Good day, Dr. Minashima. Thank you for the lecture. From your experience, do you think there is significant benefit to routinely combining amyloid PET with other imaging modalities such as MRI?
Right. So I think combination of imaging imaging technologies. So there is one efficacy of the imaging technology is one, but also the other important constellation is the cost. And the reason I'm saying cost is that no matter how we see it, the healthcare dollar is limited for the country, and the Alzheimer dementia is a very prevalent disease. So the best way is to use examination tests is to combine in the most effective way to get to the best possible diagnostic accuracy. And so if the patient typically well characterized by neurologist or a psychiatrist or geriatric physician, medicine physician, majority of the dementia patient well characterized probable Alzheimer disease, everything can stop there. And instead of actually getting FDG PET or amyloid PET. But those patients with an atypical feature, or the clinician cannot really say based on the neurological exams or neuropsychological exams, AD versus FTD, and think about cholinesterase inhibitor treatment, those atypical case, questionable case, the next one to do is probably FDG PET, unless if there is an anti-amyloid therapy trial is ongoing. Because FDG PET can, it's cheaper, at least in the United States. It depends on the country. United States, it's really cheap. I shouldn't say cheap, inexpensive. It's like 1/10 of amyloid scan or 1/7 of amyloid scan. So we should go after less expensive scan with a reasonably high, accurate. MRI need to be done almost all the patient comes to neurology variation. I think it's becoming more common in the dementia clinic. So MRI, blood test, neurological workup, and some questionable cases, FDG PET scan, then maybe to go to amyloid scan.
Thank you, Doctor. So, for the interest of time, we'll take one more question. Um, thank you very much for your lecture, Dr. Minishona. What do you think is the most promising next best thing in the future of dementia and neurologic imaging?
Best technology?
Outcome or technology, imaging or tracers in the future of dementia and neuroimaging?
That's a very that's a big question, and so if you actually take a look at the imaging development, it's interesting in a way that there is a very basic human imaging investigation still looking at the pathophysiological changes such as receptor expression and connectivity and using fMRI and the proteomic imaging such as amyloid PET, tau PET, and some other markers such as synaptic vesicles. So there are many pathophysiologic investigations ongoing. But then if you take a look at the therapeutic development, so what drug companies actually developing targeting drugs, and it would be ideal if we have PET imaging matches with drug development. So the largest number still is amyloid PET imaging, but the tau-based treatment is probably the second. They're not necessarily succeeding, but also there are lots of drug companies looking at the neuroinflammation. There are a few companies looking at the synaptic modulation, including synaptic vesicular expression, all of those things. And another interesting domain is non-drug treatment for dementia. So instead of trying to treat dementia just by drug, there are lots of cognitive behavioral changes, or actually there is a physics approach such as ultrasound-based treatment, or even there is a low-dose radiation-based treatment. So I think looking at what's happening in the therapeutic development and what's happening in the imaging development, and maybe future is kind of an area of overlapping ideas, comes from a therapy as well as imaging. That is going to be probably most exciting field. But there are so many efforts ongoing, and that itself is really exciting.
I think there are no more questions. On behalf of the Department of Nuclear Medicine and Theranostics, we would like to thank Professor Minoshima for giving us a lecture with his expertise and insights. We also would like to thank all the attendees for participating in this webinar.
Oh, thank you very much.
It's my honor to present, as a token of appreciation, the St. Luke's Medical Center awards the Certificate of Appreciation to Professor Dr. Satoshi Minashima for delivering his lecture entitled Amyloid PET, Brain PET in Advancing Alzheimer's Disease Detection virtually on August 15, 2022. Signed by Dr. Eric Cruz, head of the Department of Nuclear Medicine and Theranostics, St. Luke's Medical Center, Quezon City. Eduardo Erasto Onqueco, Assistant Head of the Department of Nuclear Medicine and Theranostics, St. Luke's Medical Center, Quezon City. And yours truly, Training Officer of the Department of Nuclear Medicine and Theranostics, St. Luke's Medical Center, Quezon City.
Thank you so much, Irene. I really appreciate it. Great to be here today. Thanks.
May we kindly request everyone to open their cameras as we virtually take our photos for documentation. Yes.
Nice.
Okay. All right. Okay, so thank you so much. Um, all right. Th- thank you, Dr. Bandong. Thank you. Okay, thank you, Dr. Bandong. Thank you, Dr. Minoshima. To wrap things up for our session today, we would like to call on one of the earliest advocates for um, amyloid brain PET imaging here in our institution. Renowned neurologist and head of the Institute of Neurosciences in St. Luke's Medical Center, Quezon City, Dr. Maria Sapporo C. Martinez. Doctora, your mic is muted. Oh, mm, 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 mm. Doctora, you may unmute your mic po. Doctora, you may unmute your mic po anytime.
Okay. I'm sorry about that. There was some technical error on my part. Okay. Good morning, everybody. First and foremost, on behalf of St. Luke's Medical Center Institute for Neurosciences and its memory service, I wish to express our appreciation to the eloquent and elegant speaker, Professor Satoshi Minoshima, for his valuable lecture on amyloid brain PET advancing Alzheimer's disease detection. Our deepest gratitude too to the Department of Nuclear Medicine and Therapeutics for organizing this webinar. Rapid research progress in Alzheimer's disease had significantly enhanced our understanding of amyloid beta as an important component of AD pathology that can be targeted therapeutically early on in the disease process, especially during the preclinical stage to halt or reverse disease progression. With emerging amyloid therapies, documentation of the patient's amyloid status through biomarkers to confirm etiology of a clinical diagnosis is warranted prior to instituting amyloid based therapy. The well validated and established biomarkers our cerebrospinal fluid amyloid beta 42, and of course, PET amyloid imaging. In our country, the minimally invasive and inexpensive method for early screening and diagnosis of AD is the blood based biomarker, the multimer detection system, oligomer amyloid beta. The multimer detect detection system, oligomeric amyloid beta, is a non invasive blood based biomarker utilized to measure alpha beta oligomerization tendency. We determine the difference in MDS oligomeric amyloid beta ratio across the groups. No cognitive impairment or subjective cognitive impairment, Alzheimer's disease, non AD and mixed Alzheimer's disease and vascular dementia, MDS oligomeric level was not significantly different between AD and mixed AD VAD, but both groups were significantly different from no cognitive impairment and subjective cognitive impairment, and from the non AD group an MDS oligomeric AB level of greater than 1 could potentially indicate clinical variants of AD or mixed pathology ADVAD. These were the findings of the extensive research done by our colleague, Dr. Jacqueline Dominguez, in cooperation with the dementia specialist in the Philippines, Drs. Ampil, Poson, and myself, and the work has been published in the International Journal of Alzheimer's Disease in May 2022. With the medical center's acquisition of the amyloid tracer F18 fluorbetabin, we have added in our armamentarium amyloid PET scan to visualize amyloid plaques with up to 90% accuracy and 91% specificity for Alzheimer's disease. We thank the kind Professor Minoshima in outlining the appropriate clinical utility of the positron emission tomography of brain amyloid beta, namely in patients with persistent or progressive unexplained mild cognitive impairment, patients satisfying core clinical criteria for possible AD because of unclear clinical presentation, either a typical clinical course or etiologically mixed presentation, patients with progressive dementia, and a typically early age of onset, usually defined as 60 years or less in age. Bear in mind that the amyloid PET imaging is only one tool that clinician can use prudently to help in decision making and managing patients with cognitive impairment. It is without saying that meticulously taken clinical history and focused neurological examination are foremost and required to understand the clinical background needed to integrate imaging results into the patient's management. It is important to take into account that in dementia care, there are two patients, not only the patient, him or herself, but likewise the family members who bear the psychological, physical, as well as emotional burden of the deceased entity. And therefore, they usually are involved in decision making. That's why clinicians should be extra judicious in establishing the diagnosis of dementia of the Alzheimer's type. The medical center, through the Institute for Neurosciences and its Memory Center, as well as the Department of Nuclear Medicine and Therapeutics, are committed to keep its staff and our targeted users on the latest advances of development in the field on the one of the most devastating and debilitating syndrome, dementia. Thank you all and a pleasant good morning to everybody.
Thank you, Dr. Martinez. And thank you, Dr. Minashima, Dr. Bandong. Thank you, everyone, for joining us here today. We hope that this has been an informative and educational session for all of us. May you all have a pleasant day. Thank you.
Thank you so much. Thanks.